Hi, welcome to NU621, Advanced Pathophysiology, Week 1, Presentation 2, Heart Failure, Simple Facts, Simple Questions. In this video, you will be given information from the 2013 American College of Cardiology, American Heart Association Guidelines for the Treatment and Management of Heart Failure. We will review the definitions of heart failure, the stages of heart failure, the New York Heart Association functional classifications for heart failure, as well as simple questions to help you apply the guidelines in your clinical practice. In the 2013 guidelines, there are two refined definitions of heart failure. The first is heart failure with reduced ejection fraction. This is when there is a left ventricular ejection fraction of less than or equal to 40%. This has been referred to as systolic heart failure. You may also see dilated cardiomyopathy as a definition similar to this. The second definition in the 2013 guidelines was heart failure with preserved ejection fraction, also referred to as diastolic heart failure. This is when there is left ventricular ejection fraction of greater than or equal to 50%. As a review, normal left ventricular ejection fraction is 55 to 70%. Some sources may give an upper limit of 75%. As you can see from the chart, there are subcategories of heart failure with preserved ejection fraction, but these will not be addressed in this video. Which of the following is not recognized as a common underlying cause of heart failure with reduced ejection fraction? A. Diabetes mellitus, B. Peripartum cardiomyopathy, C. Supraventricular arrhythmias, or D. Neurofibromatosis type 1. The correct answer is D. Neurofibromatosis type 1. Causes of heart failure with reduced ejection fraction include coronary artery disease, which is the most common cause, and this is due to the chronic ischemic condition that results from reduced blood flow to an area of the myocardium due to blockages and atherosclerotic plaque in the coronary arteries, causing apoptosis, cell death, and actual changes in the structure of the myocardium. Diabetes mellitus, hypertension, valvular heart disease, whether it's stenotic or regurgitation, arrhythmias, either supraventricular or ventricular, infections and inflammations such as myocarditis or pericarditis, peripartum cardiomyopathy, congenital heart disease, drugs such as alcohol or cocaine, and even therapeutic drugs with cardiac side effects, such as chemotherapeutic agents like doxorubicin, idiopathic cardiomyopathy, and rare conditions which include endocrine abnormalities such as hyper and hypothyroidism, rheumatologic diseases such as scleroderma, and neuromuscular conditions such as muscular dystrophy. Which of the following American College of Cardiology and American Heart Association stages do the majority of patients with heart failure fall under? A. Stage A, B. Stage B, C. Stage C, or D. Stage D? The correct answer is C. Stage C. The stages of heart failure are A, B, C, and D. Stage A are people with risk factors that place them at high risk for developing heart failure in the future, but do not have structural heart disease or symptoms of heart failure. Stage B is structural heart disease is documented, but there are no signs or symptoms of heart failure. Stage C, in which most people fall, is documented structural heart disease with current symptoms of heart failure, or they have had prior symptoms of heart failure. Stage D is refractory heart failure requiring specialized interventions. This is severe heart failure. Once a patient has been classified in a stage, they cannot go backwards. In other words, they are classified as stage C. They cannot regress to stage B. It's not reversible. But they can progress to stage D. New York Heart Association functional classifications are to enumerate the amount of physical activity that a person can perform without symptoms of heart failure, or how much activity they can perform before the symptoms of heart failure, such as fatigue and shortness of breath, occur. New York Heart Association Class 1 is no physical limitations. That ordinary physical activity does not cause symptoms of heart failure. This can be patients with stages A, B, or C. New York Heart Association Class 2 is there a slight limitation of physical activity. Patient is comfortable at rest, but ordinary physical activity can result in symptoms of heart failure. This can be your activities of daily living. Classification C is there is a marked limitation of physical activity before symptoms occur. They're comfortable at rest, but less than ordinary activity causes symptoms of heart failure. This may be walking across the room. It may even be brushing their teeth. And they develop shortness of breath and fatigue. New York Heart Association Class 4 is symptoms at rest, and any physical activity results in symptoms of heart failure. I do want to mention one other thing, so I'm going to go back to that slide. You can move between New York Heart Association classifications of function. This is what happens when the use of medications improves and eliminates their symptoms. Now, which of the following should be avoided in patients with heart failure? A, diuretics, B, digoxin, C, anticoagulants, or D, calcium channel blockers. The correct answer is D, calcium channel blockers. These have been shown to worsen ventricular function due to their action of slowing the exchange of calcium across the cell membrane. As you know, calcium is necessary for contractility, and these people already have reduced contractility, and we don't want to make that worse. Other medications that have shown to cause problems for people with heart failure with reduced ejection fraction are NSAIDs and most antiarrhythmic agents. These have all been shown to exacerbate heart failure and should be avoided. NSAIDs can cause sodium retention, peripheral vasoconstriction, can attenuate the efficacy of the ACE inhibitors, and they can enhance the toxicity of diuretics and ACE inhibitors. Drugs found to be beneficial for the treatment of heart failure with reduced ejection fraction include ACE inhibitors and angiotensin receptor blockers, or ARBs. These are used in patients who cannot tolerate ACE inhibitors. Beta blockers, and there are 3 that have been approved for the use of heart failure patients. Bisoprolol, metoprolol succinate, and carvedilol. The other beta blockers have not been studied and so are not recommended. Loop diuretics for fluid retention. These can be used intermittently or daily. Also, aldosterone receptor blockers such as spironolactone has been shown to be beneficial because it improves morbidity and mortality. Hydralazine and nitrates in combination has also been shown to help with heart failure treatment. Cardiac resynchronization, such as a biventricular pacemaker, has been shown to be beneficial. Any questions? Please email me through Blackboard or call me on my cell. Thanks.